Let me tell you about a man named Gerald. Gerald was 71 years old, retired engineer, sharp, methodical, the kind of man who kept a logbook of his car's mileage for 30 years. His wife called him the most disciplined person she had ever met. But for the last 3 years, Gerald had been waking up 2, sometimes 3 times every night. He would lie awake for 40 minutes after each bathroom trip, staring at the ceiling, calculating how many hours of sleep he had left. By morning, he was exhausted before the day even started. His concentration was shot. His patience, which had always been one of his defining qualities, was gone. His doctor told him it was his prostate, gave him a medication. The nighttime trips continued. His wife told him to drink less water after 6. He tried it. Nothing changed. He bought a waterproof mattress cover just in case and felt humiliated about it. What nobody told Gerald, and what I want you to hear right now, is that his nighttime bathroom trips had almost nothing to do with his bladder. They had everything to do with a hormone. A hormone his body had quietly stopped producing at the right time of night. And once we address that one biological shift, along with 2 other factors I'm going to explain today, Gerald went from 3 bathroom trips a night to 1, then to 0 in under 6 weeks. This is not a bladder story. This is a biology story. And today I'm going to tell it to you completely. I'm Dr. Arthur Sterling, and this is Dr. BodySignal, where we decode the exact signals your body is sending you and give you the research-backed response to each one. Today we're talking about nocturia, the medical term for waking up to urinate 1 or more times per night. And I need to tell you up front, this is one of the most mismanaged conditions in adults over 55. Not because medicine doesn't have answers, because the wrong question keeps getting asked. Before we go further, I want to hear from you. Drop a comment right now and tell me, how many times are you waking up per night? Because that number tells me quite a lot about which of the 3 causes I'm going to explain today is most likely driving yours. Stay with me through all 3, because the 3rd cause is the one nobody talks about, and it may be the one that changes everything for you. But first, I need to give you the biology, because without it, none of the solutions will make sense, and with it, every solution becomes obvious. Here is what your body is supposed to do at night. Your brain produces a hormone called antidiuretic hormone, ADH, also known as vasopressin. Its job is simple and elegant. When darkness falls and your body shifts into sleep mode, ADH signals your kidneys to slow urine production dramatically. Your kidneys listen. Urine output at night should be roughly 40% of what it is during the day. The result in a young, healthy adult is 8 hours of uninterrupted sleep with no bathroom urgency whatsoever. The system works beautifully. Here's what happens after 55. ADH production begins to decline. Not dramatically, not all at once, gradually, quietly, year by year. Your kidneys, which have been following ADH instructions reliably for decades, start receiving a weaker signal. They continue producing urine at a rate closer to daytime levels. Your bladder fills, you wake up. This is not a bladder problem. Your bladder is working exactly as designed. It's telling you it's full because it is full, because your kidneys never slowed down the way they were supposed to. And here is the second biological shift happening simultaneously, and this one surprises almost everyone I explain it to. Your bladder's capacity changes with age. In a younger adult, the bladder holds approximately 500 milliliters before sending an urgent signal. In an adult over 65, that functional capacity frequently drops to 300 milliliters or less. Not because anything is wrong with the bladder structurally, but because of changes in the nervous system that controls the threshold at which the urge signal fires. So you have more urine being produced at night, filling a bladder that now signals urgency at a lower volume. Those 2 shifts together create the perfect biological setup for nocturia, and they are happening in the background invisibly, while everyone focuses on the prostate or the bladder as the supposed problem. Now, the 3 causes. And I promised you I would tell you which ones are most likely working together in your body. Let's go through them in order. If you are still with me and this is landing clearly, type the number 1 in the comments. I read every single one and I want to know who is here with me today. Cause number 1 is the one I just described, nocturnal polyuria, the medical term for producing too much urine at night relative to daytime output. This is the most common underlying driver of nocturia in adults over 60, and it is almost universally underidentified in a standard clinical visit. Here is how to know if this is your primary driver. If your nighttime bathroom trips produce large volumes of urine, a full or nearly full void each time, that is nocturnal polyuria. Your bladder is not firing prematurely. It is genuinely full because your kidneys produce too much fluid overnight. The research is sobering. A 2020 review published in Nature Reviews Urology found that nocturnal polyuria accounts for approximately 88% of nocturia cases in adults over 65. 88%. And yet most patients are prescribed bladder medications that do nothing to address kidney output. Gerald's situation, the man I told you about at the beginning, this was his primary driver. So what actually helps nocturnal polyuria specifically? The single most evidence-supported intervention is something called fluid timing management. And I want to be precise here because this is widely misunderstood. The advice to simply drink less water is wrong and potentially dangerous. Dehydration in older adults carries its own serious risks. Concentrated urine irritates the bladder, increasing urgency, and it does not solve the underlying hormonal deficit that is causing nocturnal polyuria. What the research supports is this: drink your fluids earlier. The goal is to front-load your hydration. The majority of your daily fluid intake consumed before 3 or 4 in the afternoon. A clinical study published in the Journal of Urology found that patients who shifted fluid intake to earlier in the day reduced nighttime urine production by an average of 32% without any medication, and without reducing total daily intake. There is also strong evidence for afternoon leg elevation, specifically lying down with your legs elevated above heart level for 30 to 60 minutes between 2 and 4 in the afternoon. This sounds unusual, so let me explain the biology. During the day, fluid accumulates in the tissues of your lower legs due to gravity, especially if you sit for long periods. When you lie down at night, this fluid redistributes into your circulation and is processed by your kidneys as urine. Elevating your legs in the afternoon accelerates that redistribution while you're awake, reducing the volume available for overnight kidney processing. A randomized controlled trial published in the Journal of the American Geriatric Society found that afternoon leg elevation combined with compression stockings during the day reduced nocturnal urine production by an average of 25% in older adults. 25% from lying on a couch with your feet up. That is the intervention for cause number 1. Cause number 2 is sleep architecture disruption. And this is the cause that most people never consider, including most physicians. Here is the question I want you to think about honestly. Do you wake up needing to urinate, or do you wake up and then decide to go? It is a subtle distinction, but it is diagnostically significant. In many adults with nocturia, particularly those over 65, the causality is actually reversed from what everyone assumes. The conventional assumption is bladder fills, signals brain, person wakes up, person goes to the bathroom. But research published in the journal Sleep Medicine Reviews found that in a substantial subset of older adults, the sequence is actually, person exits deep sleep for an unrelated reason, becomes aware of a partially full bladder that would not have woken them in a deeper sleep state, and then goes to the bathroom. The bladder did not wake them, the shallow sleep did. The bladder just gave them somewhere to go. Sleep becomes significantly lighter and more fragmented with age. The proportion of time spent in deep, slow-wave sleep, the stage during which minor physical sensations like a partially full bladder are effectively filtered out, decreases steadily. Adults over 65 spend substantially less time in slow-wave sleep than they did at 40, meaning their arousal threshold is lower and minor sensations that would have been ignored in deeper sleep now reach consciousness. This means that for many people, the path to fewer nighttime bathroom trips does not run through the bladder at all. It runs through sleep quality. And here is where the two causes interact. When nocturnal polyuria keeps someone waking repeatedly, it fragments their sleep architecture. Fragmented sleep reduces the time spent in deep sleep. Shallower sleep makes subsequent awakenings more likely even when the bladder is less full. The two causes feed each other in a self-reinforcing cycle that worsens over months and years. Type the word cycle in the comments if this is describing your experience, because recognizing the pattern is the first step to breaking it. So what specifically supports sleep architecture in adults over 60? 3 interventions have the strongest evidence base. First, temperature. Core body temperature must drop for the body to initiate and maintain deep sleep. Research consistently shows that a bedroom temperature between 65 and 68 degrees Fahrenheit 18 to 20 degrees Celsius produces measurably better slow-wave sleep duration in older adults compared to warmer environments. This is one of the most impactful zero-cost changes available. Second, light exposure management. Bright light in the 2 hours before bed from screens, overhead lighting, or bright rooms suppresses melatonin production and delays the brain's sleep initiation signal. This is not news. What is less understood is that this suppression is more pronounced in older adults because the suprachiasmatic nucleus, the brain's master clock, becomes less sensitive to light cues with age, making the timing of light exposure more consequential, not less. Dimming your environment aggressively in the 90 minutes before bed using amber or warm spectrum lighting rather than blue-white overhead lights has been shown in controlled studies to extend slow-wave sleep duration by 15 to 20% in adults over 60. Third, and this one requires some willpower, consistent wake time. Your brain's sleep pressure system, the accumulation of a chemical called adenosine during waking hours, is one of the primary drivers of sleep depth. When you sleep in after a difficult night, you partially discharge the sleep pressure that would have driven deeper sleep the following night, creating a cycle of shallow, fragmented sleep that persists indefinitely. Waking at the same time every day, including after difficult nights, rebuilds sleep pressure and gradually restores deeper sleep architecture over 2 to 4 weeks. These are not minor lifestyle suggestions. They are mechanistically grounded interventions with documented effects on sleep structure, and they directly address cause number 2 of nocturia. Cause number 3 is the one that most videos on this topic never address, and it is the cause that in my experience produces the most relief when people discover it because they had never once considered it a possibility. It is evening sodium intake. I want you to think back to your last difficult night. What did you have for dinner? Did it include restaurant food, takeout, canned soup, a processed meal, salty crackers, aged cheese, pickles, anything from a package with a significant sodium content? Here is the biology. Sodium is an osmotically active substance. That means it pulls water toward it. When you consume high sodium food in the evening, your body retains water to dilute and balance that sodium load, a physiological process called osmotic equilibration. That retained fluid must eventually be processed and excreted, and the timing of its excretion coincides almost precisely with your overnight sleep window. A landmark clinical trial published in the journal Circulation followed adults with nocturia and reduced their evening sodium intake from high to moderate levels, specifically targeting the meal between 5 and 9 in the evening. After 12 weeks, participants experienced an average reduction of 1 full nighttime bathroom trip. Not a small or marginal effect. 1 full trip eliminated through dietary modification alone. And this cause interacts with cause number 1 in a way that is particularly important to understand. Nocturnal polyuria creates excess overnight urine volume. High evening sodium adds an additional bolus of fluid to that already elevated overnight load. Together, they can produce a volume that overwhelms even a well-functioning bladder. The practical target, supported by the clinical evidence, is keeping evening meal sodium below 500 milligrams. For reference, a standard serving of canned soup frequently contains 800 to 1200 milligrams. A restaurant entree may contain 1500 or more. A home-cooked meal of lean protein, vegetables, and whole grains, seasoned with herbs rather than salt, can comfortably come in under 300 milligrams. I am not asking you to eliminate sodium from your life. I am asking you to shift when you consume it. Your kidneys will thank you between midnight and 6 in the morning. Now let me give you the full protocol. Organized the same way I give it to every person I work with. Tonight, tomorrow, this week. Tonight, before bed, elevate the head of your bed or use a firm wedge pillow. Even a small incline, 10 to 15 degrees, uses gravity to reduce the redistribution of lower leg fluid while you sleep, keeping more of it in the peripheral tissues rather than being processed by your kidneys. Set your bedroom temperature to 65 to 68 degrees. Dim all lights in your home 90 minutes before your intended sleep time. If you wake tonight and the urge is present but not urgent, try lying completely still for 60 to 90 seconds before getting up. In many cases of sleep architecture-driven nocturia, the sensation partially resolves as you return to a slightly deeper sleep state. This is not advice to ignore a genuine urgent need. It is a technique to distinguish between true urgency and light sleep arousal. Tomorrow afternoon, between 2 and 4 o'clock, lie down with your legs elevated above heart level for 30 to 60 minutes. Use a pillow under your calves or prop your feet on the arm of a couch. This is your most impactful single afternoon intervention. If you sit for long periods during the day, wear compression stockings. This reduces the daytime fluid accumulation in your lower legs that redistributes at night. Tomorrow evening, plan your dinner with sodium awareness. Home-cooked protein, vegetables, minimal added salt. Stop fluid intake, all fluids including herbal tea, 2 hours before your intended sleep time. Not 3 hours, not 1 hour. 2 hours is the evidence-supported window for meaningful reduction in bladder filling during the critical first sleep cycle. This week, commit to a fixed wake time every morning, regardless of how the night went. Choose a time and hold it for 14 consecutive days. Within 2 weeks, the majority of people notice a measurable improvement in sleep depth that directly reduces light sleep-triggered bathroom trips. Before I close, I need to address some questions I know are forming right now. What if I take a diuretic, a water pill for blood pressure? Can I still apply any of this? Yes, and this is actually critically important information. Many diuretics are prescribed to be taken in the morning specifically to avoid nighttime urination. But patients are frequently never told this. If you take your diuretic in the evening or afternoon, talk to your prescribing physician about moving it to morning administration. This single timing change in multiple clinical studies has reduced nocturia episodes by 30 to 50% in patients on loop diuretics without changing the dose or the medication at all. What if I have an enlarged prostate? Does anything I said today still apply? Benign prostatic hyperplasia, BPH, can absolutely contribute to nocturia through reduced bladder emptying and increased urgency. But here is what the research consistently shows. In men with both BPH and nocturnal polyuria, treating the nocturnal polyuria alone reduces nighttime trips significantly, even without addressing the prostate. The two conditions coexist frequently, but they respond to different interventions. Everything I described today applies regardless of prostate status. I've tried going to the bathroom right before bed to empty out. Why doesn't that help? Because if nocturnal polyuria is your primary driver, your kidneys produce the urine after you've gone to bed, not before. You can empty your bladder completely at 11 p.m. and have a full bladder again by 1 a.m. because your kidneys continued working through the night. Pre-bed voiding helps modestly for people with reduced bladder capacity, but it does not address overnight urine production. How long before I see a meaningful difference? The fluid timing and sodium interventions can produce noticeable change within 3 to 7 days. The sleep architecture interventions, consistent wake time, temperature, light management, typically require 2 to 4 weeks of consistency before the change in sleep depth becomes apparent. The leg elevation intervention produces the most variable timeline. Some people notice it within a week, others over 4 to 6 weeks. Be patient with it. What I want you to take away from today is this. Waking up at night is not simply getting older. It is not something you have to accept. It is not a permanent feature of your life beyond 60. It is 3 specific, identifiable, addressable physiological processes. Reduced ADH production leading to nocturnal polyuria. Fragmented sleep architecture with a lower arousal threshold. And evening sodium intake amplifying overnight fluid load. Gerald is sleeping through the night now. He still keeps his car mileage logbook, but he no longer keeps a mental count of his bathroom trips. You deserve the same. If this video gave you something concrete today, a mechanism that finally made sense, a protocol you can start tonight, please hit the subscribe button right now and click the notification bell. Because every week on this channel, Dr. Arthur Sterling decodes another signal your body is sending you and gives you the research-backed response to it. And before you go, drop a comment telling me which of the 3 causes you think is most relevant to your situation. Nocturnal polyuria, sleep architecture, evening sodium, or a combination of all 3. I read every comment, and your answer helps me understand what this community needs most. Your body is not failing you, it is communicating with you. Today you learned how to respond. Take good care.